Hello, welcome back to another example of a head-to-toe scanning demonstration. In this example, it's going to be an axillary nerve block scanning demonstration. I'm Brandon Winchester. I'm the co-founder of blockjocks.com. And today, after having already demonstrated all of the more proximal brachial plexus scanning techniques, the interscaling, supraclavicular, and infraclavicular, we're now going to round out the fourth of four options for a brachial plexus block, and that is the axillary brachial plexus block. I often get asked about the comparison between supraclav, infraclav, and axillary, about the decision tree between each three. And like we talked about in the last video, it's very easy to interchange the supraclav, infraclav, and axillary for pretty much all the major surgeries from about mid-upper arm and down. That's been well proven despite a classic paradigm that says that the more superficial blocks, or excuse me, the more proximal blocks like the supraclavicular are better for proximal surgeries. The more distal blocks like axillary are better for distal surgeries, and the mid blocks like infraclavicular better for the mid-range surgeries around the elbow or so. That has actually been disproven, and certainly in our clinical practice these three blocks are interchangeable, which begs the question then, well, when do you use an axillary nerve block? If the supraclavicular is the spinal of the arm and your preference is the infraclavicular, well, when is it that you use an axillary brachial plexus block? Well, it's an excellent question. There's two main ways in my decision tree that I decide that an axillary is the preferred choice. The first has to do with the patient's size. If the patient is a morbidly obese patient, then I tend to at least consider and favor a more superficial technique, no matter which block we're doing. And in this particular instance, an axillary block between those three choices is certainly the most superficial of the three. More superficial means that the needle insertion is going to be flatter and therefore better able to be visualized. And so for a morbidly obese patient, having a brachial plexus block, an axillary is a real consideration. The second consideration is whether the patient needs a continuous catheter or not. A supraclavicular is a reasonable choice, an infraclavicular is a reasonable choice for a catheter, probably even a better choice based upon certain studies that have been done. An axillary brachial plexus block, I don't think is such a good choice for a continuous catheter. You'll see articles written about it, you'll even see a white paper written about it. An axillary brachial plexus block, in my opinion, is not a great choice for a continuous catheter for two reasons. One is that there's a lot of blood vessels that surround the nerves of the brachial plexus at that location, and I think it's very easy to get near or even through inadvertently some of those veins around the nerves. Making a continuous infusion, especially if you're sending them home, increased potentially the likelihood of intravascular absorption or injection or both. That's one consideration. The other important consideration is that at this location, the nerves are very spread out. Now, for a single injection nerve block, that's not a particularly big deal. It just means that to get musculocutaneous, median, ulnar, and radial, all those three components, or excuse me, four components of the brachial plexus, you need to do a little bit of needle redirection and target each of those four components one by one. That works great for a single shot, but finding a location for a continuous catheter that targets all four of those nerve locations is much more challenging, and therefore with an axillary catheter versus a more proximal catheter like an infraclavicular, I don't think you're going to get as good of local anesthesia spread, and therefore I don't think you're going to have as high of a success with your postoperative secondary analgesia derived from the catheter versus your single injection primary anesthesia, which I think is a coin flip as far as which is preferred versus the other. So generally speaking, morbidly obese patients with deep proximal brachial plexi that don't need a continuous catheter, that's an excellent time. That's the time and the place that everybody always wants to know as to when I prefer to do an axillary nerve block. So when we're doing an axillary nerve block, the preferred probe choice is most definitely a wide, linear, high-frequency transducer. It's a very superficial target, and high frequencies will get you much better resolution for superficial structures. So this is as good of an example as any of when you want to use a linear transducer. Although, as I've mentioned before, the linear transducer is what we use 99% of the blocks that we do. So no big surprise that we use it for a very superficial block like the axillary block. So as far as the starting depth settings, you usually, because it's so superficial, can crank your depth down to about 2.7 or 3 or 3.3, somewhere around that range, in order to adequately predict where the targets are going to be, where the landmarks are going to be. You can certainly adjust accordingly, more superficial or more deep, once you've started to scan. But usually your starting scanning depth is very superficial, somewhere in the 2.7 to 3.3 range. Now, as far as the probe placement, in just a moment, I'm going to show you the place that you put your probe. And as you'll notice, it's very similar to the infraclavicular technique that we've scanned before. Now, notice that the patient's arm position is in the Houdini arm clavicle position that we described for the infraclavicular block. Now, the reason for this is not because of the displacement of the clavicle as it was for the infraclavicular block. The reason for this is simply that you can't access the axilla without moving the arm into that same position. So you can already notice that this arm position change is identical to the arm change that we use for an infraclavicular block. Now, that deltopectoral groove where we place our probe for the infraclavicular is more medial than the axillary, which is right here. And as you can see, there's essentially a groove just lateral to the pectoralis muscles, just lateral to the shoulder, where things become much more superficial in the axilla. That's the location that you're going to put your probe. So generally speaking, you want your probe in the axilla as high up as you can go before the tissue starts to become deeper as you get to the more muscular pecs and deltoids. You can see I'm as high in the axilla as I can go. One of the common mistakes that you see people make is they do an axillary brachial plexus block and they're too far down the arm. So you want to be as high in that axilla as you can, but not so high that it becomes deeper tissue like it is as you get up towards the shoulder and pectoralis muscles. At this location, you have a very superficial insertion site to insert your needle and can therefore approach the nerves with a very flat angle of entry. Now, I want to point out some of the basic ultrasonographic anatomy now that we've got a picture that we can work with here. First and foremost, as with many of the major blocks that we do, your first landmark of importance is to find a major vessel. In this case, like the infraclavicular block, it's the axillary artery. You can see that artery pulsating on the screen. It's not much doubt in your mind that that is an artery. But if ever in doubt, you can always activate color flow, move the color flow over the artery, and see the pulsatile flow to confirm that you're looking at artery versus vein. Now, I have a fair amount of pressure on my ultrasound transducer, so if I relax that pressure, notice a few monster-sized veins, in one particular case at around the 1 o'clock relative to the artery. Those veins were compressed prior to my releasing the pressure on my probe. So once in a while you're doing an ultrasound-guided axillary block, it's a good idea as your needle's going in to release your pressure on your probe intermittently, increasing pressure and decreasing pressure, to allow yourself to better visualize the vessels that you may not otherwise visualize because they're being compressed. I think that may lessen your likelihood of incidental puncture of one of those veins. Like always, though, you want to turn your color flow off before proceeding with your nerve block, because otherwise it will degrade the ultrasound image. A couple of other landmarks of importance here are muscular landmarks and planes. Out lateral to the artery and the needle side. This large muscle belly here is your biceps muscle. The deeper belly of the muscle deep to the biceps is the coracobrachialis muscle. And this bright white plane is important because that bright white plane is the superficial border of the teres major muscle. And if you put your needle just deep to that artery and you inject, that tissue plane, that fascial plane superficial to the teres major muscle, is going to keep that local anesthetic encased above. It's going to compartmentalize that local anesthetic above the muscle and therefore allow better spread to get to all the nerve components of the brachial plexus around that artery. Now, the exception to the nerve components that are around that artery that you still need to block is the musculocutaneous. And typically the musculocutaneous lies between the biceps muscle and the coracobrachialis muscle. In her particular case, you can see a bright white nerve right about here that is the musculocutaneous nerve. And I think that that brings an important point to light, that in her, being no exception to the rule, generally speaking, every single axillary plexus block is going to look a little bit different than any previous axillary brachial plexus block that you've done. In other words, no two axillary plexi are alike. You know, you'll read things that are sort of quote-unquote classic in the textbooks as far as locations for nerves relative to vessels, nerve relative to muscles. In this particular case, it does seem to vary quite a bit. And so, you know, you're looking for that musculocutaneous nerve oftentimes in this region, and it's usually very bright white. But just to point out that there are variations, hers is a little more superficial here. Now, how do I know that's a nerve? Besides just the classic appearance of the nerve being kind of a honeycomb appearance, if I scan down the arm, You can see the nerve remains bright white and visible. If I scan up the arm, it starts to travel more and more medially, more and more towards the artery. So down the arm, not only is it followable, but it's moving away from the artery. Up the arm, it's moving medially and remains followable. So that's going to be our first target. And notice that that musculocutaneous is very far from the area around that artery. So we're going to have to target that nerve completely separately from the remaining nerves of the brachial plexus. Now traditionally, the radial nerve is described at about the 6 o'clock position. Now in her particular case, I really don't see any nerve tissue at the 6 o'clock position. She has what I call the parachute sign, where the nerves, median, ulnar, and radial, are kind of parachuted all on one side of the artery. I don't know if that's an embryologic phenomenon. I'm not sure why that is, but with fair frequency, you'll see all three of those nerve components on one side of the artery, as if they were all connected to the parachute and somebody pulled the string towards the left and they sort of all parachuted out on one side of that artery. So median, ulnar, and radial, and that's always a somewhat speculative which of those nerves is which. The ultimate determining factor would be to put a needle tip right on that musculocutaneous nerve and stimulate it. That would cause a biceps twitch. To put a needle tip right on that radial component of the nerve, that would cause an extension twitch of the fingers, wrist, or elbow. To put a needle tip on that median nerve, which would cause intrinsic hand muscle twitch, or to put a needle tip on that ulnar nerve, which would cause a twitch, an ulnar deviation twitch at the wrist, at the pinky side of the wrist. So although that nerve stimulation, dual guidance can be helpful, it's not absolutely necessary with this particular block, provided that you find, identify, and inject local anesthesia around the musculocutaneous nerve with approximately 5 cc's, and then with the remaining 25 to 30 cc's of local anesthetic, completely encircle your axillary artery. The combination of those two steps is going to give you a very high success rate with a very reasonable onset time for this nerve block. But again, if you wanted to combine ultrasound with nerve stimulation, musculocutaneous will give you the biceps twitch, radial will give you extension twitch, median will give you intrinsic hand, and ulnar will give you ulnar deviation twitch. Again, it's always a single injection nerve block. In our practice, it's typically going to be a 30 cc, 0.5% plain bupivacaine solution if we're using it for a long-acting block, or 30 cc's of 1% lidocaine plain if we're using it for a very short-acting block, like say for an endoscopic carpal tunnel syndrome, which we mainly want it for primary surgical anesthesia but don't care about the duration of analgesia afterwards because frankly they don't hurt that much afterwards. Generally speaking though, we do use bupivacaine to capitalize on the longer duration of action. So going back to the insertion site for the infraclavicular block, because it's a fairly deep structure and because we want to visualize our needle well, typically the infraclavicular block is going to be inserted several centimeters away from the probe. With an axillary brachial plexus block, the probe insertion distance is not as critical. And the reason for that is that, if it's injected right next to the probe, it's still not a very deep angle of insertion at a depth, which in our screen is only about 1 centimeter to 1.5 centimeters for the targets. So for two reasons in this particular block, you actually do benefit from going a little bit closer to the probe. The first is that you don't need to go further away from the probe and therefore go through tissue, a longer distance of tissue, because it's not going to improve your needle views any. The second is that because this nerve block involves so much needle redirection to get all 4 of those nerve territories, it actually behooves you, it benefits you to insert a little bit closer to the probe because your needle redirection is actually going to be easier the closer to the probe you insert. Now I wouldn't do like a lot of the websites show you and put a needle in literally right next to the probe. I still think that's not wise. I think it's still beneficial to have a 1 to 2 centimeter distance between your probe and your needle insertion. That pressure of the probe alone is going to be less likely to displace the needle tip with each time you put pressure on. If the needle's right next to the probe, pressure on the probe will actually directly displace the needle tip and make it harder to visualize and to insert. So even though it's superficial, a little bit of distance from the probe, 1 to 2 centimeters, but not as much because you will benefit in your redirection technique by inserting closer to the probe with no downside since it's so superficial. And as you insert your needle approximately 1 to 2 centimeters lateral to that probe, you're going to be approaching from the left to right of the screen, lateral to medial, and you're first going to encounter musculocutaneous. You're going to inject 5 cc's of local anesthetic either after you see the needle approach the nerve, or if you want to combine dual guidance after you see a biceps twitch. In that case, I'm going to pull back, redirect, occasionally relaxing the pressure of my probe so that I can make sure that I'm not approaching any veins. And at this point, I'm going to use a hydrodissection technique. I'm going to get my needle tip just deep to that artery, and I'm going to inject 5 cc's as I advance. And that local anesthetic injection acts like a jet, and it pushes the artery up, and it pushes the teres major plane down, and allows that needle to glide essentially under that artery and down under and past the radial nerve, which lies just under and past in this particular patient's example. So about 5 cc's there, another 5 cc's as I continue to advance. At that point, I've given about 15 cc's, about 10 of which is under and past the artery. At that point, I'll pull back my needle. I always want to be very cautious when I pull back and redirect above the artery, that I don't pith, that I don't injure the musculocutaneous nerve. In this particular case, the musculocutaneous is very superficial, so that redirection should not come into contact with that musculocutaneous nerve. But if it's in its usual location, you do have to be very cautious that that needle redirection does not encounter and therefore injure the musculocutaneous nerve. You always have to be aware of where the tip is relative to that nerve. But after about 15 cc's are in, I'll pull back, flatten out my angle of insertion, and inject just above the artery. Again, hydrodissecting over the artery, steepening a little bit to get local anesthesia under the median and ulnar nerves, pulling back after about 5 cc's, and injecting about another 5 cc's over the top of both median and ulnar nerve. At that point, we've given typically about 25 cc's of local out of our total dose of 30 cc's of local. At that point, I'll take a moment to scan, see if there's any component of the radial, ulnar, or median that has been inadequately covered, and I'll take whatever remaining volume I have in the syringe and target that particular area, with the goal being a donut around musculocutaneous, radial, ulnar, and median by the time that I'm done, if in an ideal world, and at the very least, a donut around musculocutaneous and a donut around the axillary artery, knowing that that is still a very effective and successful mechanism to do this nerve block. So that concludes the scanning demonstration for an axillary brachial plexus block. As we discussed earlier, I don't have any talking points for continuous catheters regarding the axillary plexus block, because I don't think that a catheter technique at this location is wise. I think that an infraclavicular or a supraclavicular is a far better choice. Hopefully that was helpful. Stay tuned for more head-to-toe scanning demonstrations of the other major nerve blocks. As always, if you have any questions, feel free to email me. Thanks a lot for watching.